Thank you very much for that very nice welcome, and thank you for inviting me this afternoon. As Manu said, I'm Jo Anne Fowles. I'm a nurse consultant and ECMO specialist in critical care and ECMO at Royal Papworth Hospital. And before I start talking about nursing issues, just a little bit about us. So I'm going to keep waving this microphone around, I apologise. We're in a brand new hospital in the centre of the Cambridge Biomedical Campus, which is part of the University of Cambridge. And we felt very special because we were opened by the Queen earlier this year, and this is our resident Belgian. Our lead consultant is from this very city, so I thought it was quite apt to put it in. So what do we do at Royal Papworth? Well, we're a very large adult intensive care area. We've got 47 beds, but currently we only have 36 of those beds open. We do over 2,000 cases per year, cardiothoracic surgical cases, and that's increasing as we've just opened our 6 theatres. We do over 100 transplants per year. Most of them are heart-lung transplants or single or lung transplants. We're also the only UK centre for pulmonary endarterectomy surgery, and we do about 150 cases per year. And this is quite important because this was actually where our ECMO service started, was on these patients post-operatively. We're a tertiary referral centre for heart failure, so we do a lot of assist devices in about BiVADs and Impeller. And of course we do VV and VA ECMO. So we're one of the 5 centres in the UK who are registered to accept patients for VV ECMO. So within our region, any patient with ARDS that requires ECMO, we'll go out, put on ECMO and bring back to our centre. And that's about 50 cases a year. So that's the sort of activity we have. So last year we had 115 runs of ECMO on 100 patients. And this year we look like we're heading in the same direction. And fairly 50-50 VA, VV. We have some VAVs, VVAs, and we have some undefinables that the surgeons send us out. And we will benchmark ourselves against ELSO on a monthly basis, and as you can see, over the last 6 months and since start of service, we punch above our weight a little bit, and we're always within fighting distance of ELSO, which we're quite proud of. And so just a little bit about how we nurse in Papworth and how we nurse in the UK, because I know it's very different from Europe, because we're very lucky we have a lot of nurses, because we have very stringent guidelines from the Intensive Care Society which state that you need 1 nurse at the bedside of every level 3 patient. So we'll have an ECMO trained nurse who's done a day's training on recognising complications with ECMO patients, helping us mobilise ECMO patients, and I've lost my train completely, and recognising if the trends of care. So if some of the parameters change, they'll call for the ECMO specialist very early on. And then we'll have an ECMO specialist who may be looking after 4 or 5 patients. We try and have them only looking after a maximum of 3 ECMO patients at any given time. And on our unit, I can't remember the last time we didn't have an ECMO patient. We tend to run with an average of 3 patients on ECMO at any given time. And through the winter, that may rise up to 8 or 9 patients. So we'll always have at least 3 ECMO specialists on a shift. And we, of course, have perfusionists, but they're there for cannulation and decannulation. They're very involved in our education programs, and they're very of great support to us. And they're also involved in our retrieval and transfer of patients. But they're not on the unit. So today I'm going to talk to you about alarm settings and mostly about how we nurse our patients. So I'm going to talk about cannula care, our circuit surveillance, what the blood flow tells us about the patient and the circuit, how we respond to pressure changes in the circuit, the observations we do, what they tell us about the patient and the circuit, a bit about positioning, about prone positioning and mobilising the patient. And you'll notice a few of these things you'll have heard already this morning. And actually one of the slides with the x-rays you've seen already this morning because they actually came from our centre. But as this great gentleman said, repetition is the mother of education. So why do we have such an emphasis on circuit surveillance and monitoring our patients? Well, of course, like all ITU patients, the primary goal is always to prevent emergencies. And then, of course, to prevent any patient complications. ELSO registry say that the component failures occur in 14.9% of ECMO runs. So our role as nurses at the bedside are to try and recognise this early so it doesn't cause a worse sequence of events than it could. So the sort of ECMO emergencies we all know we have pump failure, you can have oxygenator failure, accidental decannulation, air embolism and cardiac arrest. So they're the main ones that we're sort of focusing on avoiding. So just a word about alarms. So why do you need a nurse at the bedside? Well, we all work in ITUs. We know there's a plethora of alarms that are going off all of the time. And we do tend to get quite immune to them or just flick the switch, oh yeah, that's been alarming all day, especially with our Levotronics pump, which is the most irritating noise in the world. So we tend to just turn it off. So nothing replaces a vigilant nurse at the bedside, keeping an eye on everything that's happening. And of course, some of the things that happen with our patient on ECMO, there are no alarms. So a patient accidentally decannulating themselves, the first thing you're going to know is you're going to have a shoe full of blood. So no alarm's going to tell you that until the patient starts to, deteriorate and it's on their monitors. The same if your gas flow stops in your ECMO, there's no alarm for that until the patient starts desaturating. So the vigilant nurse is the gateway to everything. So when we talk about circuit surveillance, we talk about 5 components really. So we always teach our nurses, start at the patient, finish at the patient. So the first point is the insertion sites, then the circuit, the equipment, the system flows and pressures, and then looking at the patient overall. So starting with the insertion sites, well, it's like any insertion site for any cannula really, so you're checking for the same things. So you're checking for any inflammation or signs of infection, checking for any bleeding. You always want clean, dry dressings, and we use a Tagaderm patch dressing. And of course pressure damage. And the pressure damage, you can start thinking about that from cannulation. So ideally you'd want your port poking outwards rather than against the skin like this one is, because that can be quite catastrophic, especially if your cannula is actually in front of the ear on a patient's face. We've got quite clear guidelines for our nursing staff. As you can imagine, we have nearly 300 nurses, so there's a lot of nurses to maintain their skills and their education. So on our CIS at the end of the bed space, we have lots of guidelines like these telling us exactly how to dress the cannula. And you've seen this before. So I lived this dream, and these are the slides, and the radiologist this morning had the sequential ones showing the cannula slipping out. And I'll admit, we didn't notice that cannula slipping out over the days. We looked at these x-rays and it was so imperceptible, we didn't really take much notice until the final day when a vigilant nurse said, I think this cannula's out a bit further, Jo. And I nearly passed out on the spot, but that's when we noticed it. And then Bobby went back and collected the x-rays and we realised what we had missed. So in response to that, we've put in place that the nurses now check and document at least once a shift the position of the cannula. And then part of our x-ray round is checking the position of the cannula against the day before. So, no one's perfect, but we're more imperfect if we don't learn from our mistakes. So what the nurses will be looking at, they'll be looking at are the sutures secure? We use sutures rather than grip locks. And you can see a lot of the patients when we put them on, especially our ARDS patients, they've been septic, they've been filled with fluid, they're all bloated up, and then they have their cannula put in, same cannula, same sutures 10 days later when they've probably lost 10, 12 kilograms of fluid. And so the sutures, like the one at the bottom here, become quite loose and are doing nothing at all. So the nurses make sure they're okay. If need be, we'll replace them. Make sure there's no slippage, and of course we check the position on the chest x-ray. And we document it all. So then if anything does happen, we can go back and see if did we miss a stage at all. And it acts as a reminder. So a nurse reminder comes up each shift to say, have you done this yet? So the next stage of our circuit surveillance is using a good old-fashioned pen torch and just looking at, is there any fibrin? Are there any clots in the circuit? There will always be a few strands of fibrin. That's just the nature of the circuit across the joins. And so it's just the education for ECMO nurses is, when do we get concerned about it? So is it at risk of entering the patient? Is it at risk of going into the oxygenator? And Viola just showed you a really nice graphic of a clot going into the pump head. So if it's about to go into the pump head, that's when we need to start getting concerned. And looking at the tubing, we have patients come back 6 months after having ECMO, and when we ask them about what do they remember about the ECMO, every single one of them doesn't mention, oh, it was horrible seeing all my blood outside my body. They all go, it was really heavy, it kept dragging. So it's really important to make sure it's well supported. So we use a headband, which is just fashioned from ET tapes, and then we use our spare clamps on the edge of the bed, and we use fixators on their arms as well, just to take that weight off the tubes. And of course, the other thing we're looking at when we're looking at the tubes is we're looking at the colour of them. And this might seem quite basic, but it's a really important step when you're looking after ECMO patients. So we all know that normally you'd have a lovely dark red and then a beautiful oxygenated bright red on the other side. But what happens if they're both dark red? What are you going to be thinking about? Yeah, so gas failure is the first thing, or disconnection. So this most often happens after you've transferred a patient. So you go onto your oxygen cylinders to transfer a patient, you come back, everyone's busy getting the patient back into bed, sorting everything out, and no one thinks to change over back onto the wall oxygen, and the gas cylinder runs dry. The first you realise, if you're not looking at your pipes, is that the patient's desaturating. So this has happened to us 2 or 3 times, and after the 3rd time we finally learn. And so what we have in place is we have a handover check. So when a patient comes back from anywhere else and is on the cylinders, we have a double check for them, the perfusionist and the nurse, to check that we've gone back onto wall oxygen, and that's decreased our amount of incidences of that happening. And of course the other thing is it can be on purpose, that we're trialling the patient off sweep. But you can appreciate in a unit that does both VV and VA ECMO, we have to be extra vigilant, because it can get, when we're really busy, a bit frantic. But what if they're both bright red? And so this obviously very rarely happens in VA ECMO, if ever. It's usually VV ECMO, because it's about recirculation. And there's 3 causes of recirculation. The most common one is the pipes are too close together. And we see this quite often when we suddenly sit our patient bolt upright after they've been quite flat and their pipes just move closer together. So that's easy to solve. The other reason is that it can be insufficient pump preload. So you've got a really dry patient, you're sucking really hard to keep that volume going around your pump. The only available fluid is the fluid that's just returning straight from the ECMO. So if you have got recirculation, you've excluded the pipes being too close together, think about the patient's fluid balance, or think about turning your pump speed down. If you can manage without as high pump speeds with a good oxygenation, then maybe turn it down if you don't want to give your patient fluid. And then the final one, and the one we rarely see, has anyone seen the final one? It's cardiac failure. So if you have a patient who's on VV ECMO and they arrest and you have to do cardiac massage, and don't try this at home, but if you stop for a bit, you'll see recirculation. Then jump back on the chest and it'll be lovely, dark red, light red again. And it's a really clever way of, probably not very ethical way, but you can really see it happening. So please don't take that as a recommendation to do it. So the other things we're looking at is obviously we're looking at air. And ELSO say that it represents 4% of all complications. I think that's quite high from our centre, and we have access on the negative side of the circuit. We've only had 4 or 5 incidences of air entrainment over 10 years on over probably nearly 800 ECMOs. So I think it's relatively low. It's just about being vigilant, about having people accessing the circuit that are trained to access the circuit, and to make sure those people who have regular updates and refreshers. There may be some benign air at the top of your oxygenator, which is probably more dangerous to try and get rid of than to leave there, so it's about recognising that. And then importantly, that all our oxygenators, whatever we use, have an exhaust at the bottom because the condensation builds up. Sometimes drips out, so a nurse, being a nice clean nurse, like to put a piece of gauze under that. We really discourage that because it can cause a pressure build-up in the gas phase, and which will impair the function. And finally, when you're doing your full circuit surveillance, it's about looking at your equipment. So have you got your backup pump if you're on a cardio help, your hand crank? Have you got your backup console and motor if you're on the Levotronics? Have you got oxygen in case of an emergency? Have you got your spare clamps? Importantly, is that all that's on your trolley? Someone hasn't stacked all the linen on the trolley or the pillows on the trolley. So if you did have an emergency, you'd have to do a full clean up before you could actually get to your pumps. And on all the pumps, we have a heater cooler, and make sure the heater cooler is functioning properly. So make sure the fan's going around so that warm water is going around your oxygenator. And then we move on to the actual flow and the pressures within the circuit. So I think we've all learnt today, we didn't know before, that our flow is determined by the patient's own volume status, the size of the cannula, where that cannula is positioned, and of course the size of the vessel. When we're looking at flow and our alarm settings, it's our low alarm setting which we're most concerned at. We tend to leave our high one at 6 to 8 litres because you don't tend to worry about too high flow. And so we set our low flow at 70% of what we expect our flow to be. And so that's our rough guide. Normally, we'd only measure our total blood flow around the circuit because you have one exit, one entry, and so it's really nice and simple. But we know that we don't always have that. So we have the really complex circuits, so the post-surgical circuits, and this was a BIVAD with left ventricular drains and PA returns, and I can't even explain, but you can see how many flow probes are on that circuit. And so you have to maintain at least 1.5 litres flow in each one of those pipes, and so you need to monitor them all. So we had this big diagram up on the wall to tell us where we were monitoring what was what on that one. But more commonly, we'll see a dual oxygenator for the very hypoxic patient, or dual cannula drainage for, again, the hypoxic patient, or the VVA patient, so draining from a vein, returning to a vein and an artery. So you've got one of your flows going into a bifurcation. And so you need to measure both the total flow and the flow in each of them. So to make that as simple as possible, we have a poster like this on our CIS, which just we measure the total flow, we minus the flow in one cannula, and that gives us the flow in the other cannula. And then we document it every hour. So we'll document that. If it's starting to go down towards 1.5, the nurse at the bedside will call the ECMO specialist. And they all know that, you know, if you don't go below 3 litres total flow. And that sounds really simple, but you'll be surprised how many of our team will maybe go around, you know, turning flow down, and just really overlook the fact that under those blankets says 2 drainage cannula. And if we don't do that, this is what happens. And it happens remarkably quickly when you drop your flow. And if this happens, the risk of that clot going into your whole circuit and destroying your whole circuit is huge. And then we move on to our pressure alarms. And thanks to at Foam ECMO for my graphics here. So we measure 3 pressures. We measure our venous drainage pressure, which is our pump preload, our return pressures, which is our pump afterload, and then the access pressure, we assess the pressure gradient across the oxygenator, which gives us an indication of the oxygenator function. And with pressures, the alarms are the opposite. We're more concerned about the high pressure on these. So we tend to set the alarm at 50 above what we'd expect. And we'll never set that above 300 because we know the oxygenator can maybe tolerate pressures above 300 mils of mercury, but the joins within our circuit probably can't, and we really don't want to risk it. And so what do they tell us? Well, the pre-pump alarm, our negative alarm, if that becomes more negative, we know the first and most common cause is probably that the patient's really fluid depleted. So look at other clinical parameters, give fluids if necessary, and also consider decreasing your revs. So just decreasing the amount of suction, so allowing the vessel to fill up and then maybe coming back up again, just partially. It might just be that you're just really desperately trying to increase that oxygen level, so you're pumping as hard as you possibly can, so you're getting sucked down around your cannula. And in that case, you just need to go lower, and that's when you maybe consider putting another cannula in, putting another oxygenator in. Or it could be the really obvious. So clot in the cannula, a kink, get your patient back into bed, put the bedsides up, kink your circuit. So once you've looked at your circuit, you then start to look at your patient for the cause. So have they got a tension pneumothorax, increase intra-abdominal pressure, tamponade, anything that's maybe collapsing the vessel, and so you can't get the fluid into your circuit. So moving around, we move around to the positive side of our circuit, and we're looking at our afterload pressures. So we measure one pressure before the oxygenator and one pressure after the oxygenator. So if they both go up, we know there's a problem between the oxygenator and the patient or in the patient. They're all the things you'd expect them to be. Are there any clots, kinks, clamps? Have you just repositioned your patient? Has something just stopping the blood flow going back? If it's not the circuit, again, consider what's happening with the patient. So is there a clinical cause? You know, consider again decreasing the flow to maintain an even flow while you try and troubleshoot what's going on. And finally, the transmembrane pressure. We know if these increase, so if the pressure before goes up but the pressure after stays down, there's something going on, usually clot within the oxygenator. And so we'll consider changing the oxygenator if we're unable to maintain gases and or if there's a decrease in flow. And the and/or is important because often there'll just be a decrease in flow and your gases are actually fine and stay fine for a long time. But if there's a decrease in flow alongside an increase in transmembrane pressures, we'll always do a planned oxygenator change out because it's much more fun to do it as a planned manoeuvre than an emergency manoeuvre. Let's moving on to our patient observations. So in addition to the routine things we do on all our patients, we just consider that your RA is going to affect your cardiac output measurements and your what your RA is, your ECMO. We always measure our saturations on our ear or our right hand. It's not important in VV ECMO, but again, we've got a lot of patients, a lot of ECMO. We do it on all our patients because it is important on the peripheral VA ECMO patients who may develop a Harlequin syndrome. Regular neuroobs because of the risk of bleeding. Most of these patients have been hypoxic, hypoperfused. Our peripheral limb observations, reperfusion line monitoring. Renal, we will attach the CVVH to the ECMO circuit. We'd much rather achieve a negative balance using CVVH than using high-dose diuretics. But if they have got a urine output, we measure the urine output. We prevent complications, so we'll always be monitoring the colour of that urine, the effluent. We'll do a plasma-free haemoglobin if we think there's a risk. We monitor our bleeding all the time. We monitor our anticoagulation. We run our VV ECMOs without any anticoagulation if need, and we don't have any complications. We routinely assess cannulation sites, and really importantly, we're always aware of the risks of hidden bleeding. So any unexplained hemoglobin drop, we would start to think, is there an abdominal problem? What's going on? An awake patient with a headache suddenly, we'll be thinking we'll probably send them to CT scan quite quickly. And of course, infection. We've got these big cannulas, so everything as clean as we possibly can. And we record all of that, so we've got a visual on any trends on our ECMO page. So patient positioning, always sit them up, always keep their head in the midline to maintain drainage. Skincare problem, these patients are often in bed for a long time. The basis of good skincare is obviously good nutrition. We use low air loss mattresses. If they have diarrhoea, we'll use a fecal drainage system as soon as possible. But alternatively, we'll get that out as soon as possible as well, because that's something else that patients remember for a long, long time. And we know prone positioning in our ARDS patients pre-ECMO is really valuable and can often avoid them going on ECMO. And the evidence is mounting that actually we should continue doing that whilst they're on ECMO. And it may be safer than adding that oxygenator or that extra drainage cannula. But planning is the most important stage, and the communication whilst we're doing it. So to facilitate that, we have a pre-proning checklist, which includes all the things you'd expect to be in there, but importantly it includes telling the family you're going to do it. Because there's nothing more distressing than having someone walk in to see their family member flat on their belly rather than on their back. And then we have another checklist which we do immediately post going prone. And that just makes sure we've got all the bits and pieces where they should be, done things like recommence the feed, check the nasogastric tube position. And so we can leave them there for 14 to 16 hours. We all like pictures, so one of our staff nurses volunteered to be flipped on his belly by a whole pile of us, and these are really, really useful because it just makes it so straightforward. So you've maybe got one or two people that have done it before, but often you'll have others that haven't, especially our medical teams who come from other hospitals. So nice pictures, straight, easy to do. And just to prove that we really do it. And we position our ECMO because they've got quite long pipes at the end of the bed all of the time. We all know that physical rehabilitation following critical illness starts from when they're in the ICU. The earlier you mobilise them, you rehab them, the sooner they come off the ventilator, they come off ECMO, they go home, and their post-recovery at home is always much improved. So as soon as we can, we'll start to wake them up. We're not always successful, but we'll keep trying with sedation breaks every day. As soon as they're awake, be they with a tracheostomy or extubated, we'll use sitting cycles, we'll use tilt tables. We'll try and get the patients out of bed at least once a day. But, you know, I realise we are very privileged. We have a huge nursing team and we use a lot of unqualified staff. The ideal is to get them outdoors. And the sun does shine in England. So, you know, on those 5 days of the year, we do try and get patients out. And this just does amazing things for both the mood of the patient, the family, and all the nurses. You can see that's all happy faces there, isn't it? And so finally, just a quick word about the end of the journey with ECMO, with the decannulation. So all of our VV patients are decannulated in the critical care area, so it's really important that the nurse prepares for this. So again, we use like a WHO-style checklist, so 4 hours before they start to prepare. So turn the heparin off, get all the equipment, all the drugs, make sure the family know that it's happening, make sure the patient knows that it's happening and prepare the patient. And then immediately prior to the procedure, exactly the same as in theatre, everyone knows what they're doing, when they're doing it and how they're doing it. And they also know what to do if things don't go to plan. And then immediately post, we have another check. And that main things in that are things like, have they got continual temperature monitoring? Because we know that hyperpyrexia post-decannulation is a huge risk. You know, have we prescribed low molecular weight heparin if we've been on IV heparin? So this just wraps it up. So we do that on every single decannulation in the unit. And so to conclude, this very wise man said that constant attention by a good nurse is as important as a major operation by a surgeon. And I think nowhere is that more evident than in intensive care, and especially in the care of our patients on ECMO. Thank you very much.